Hello, everyone. My name is Professor Peter Nash from Department of Medicine, Griffith University in beautiful downtown Brisbane. And the question today is, what clinical factors will guide a decision for a clinician to initiate either an IL-23 or IL-17 inhibitor in patients with psoriatic disease? It's great that we've even got this choice, because these two classes of drugs have rewritten the expectations for the management of psoriasis and have been very effective and very efficient in psoriatic arthritis as well. So the 17s have a broad domain cover from fantastic skin and nails to axial, peripheral joints, etc. So if you're looking for something to cover all domains that are important in psoriatic disease, a 17 inhibitor does that. And by the way, the huge advantage of the 17s and the 23s is their incredible safety. And that's why they're being used in many clinical situations as alternate first-line options for people with risk factors, etc. But picking between the two, so I've discussed the 17s. The only flaw in the makeup of the 17s is some candida risk, particularly in those prone to candida, usually easily managed, and very uncommon risk of inflammatory bowel disease, whether that's 1 in 1,000 in psoriatic disease or 5 to 7 in 1,000 for axial spondyloarthropathies. But otherwise, everything else is covered. Now, the IL-23 inhibitors are very safe as well, fantastic for skin and nails, work beautifully for peripheral joints, but as yet, apart from a post-hoc analysis of 30% of one registration trial or two, the axial disease is not covered. So if you want to cover all the domains except axial disease, and the big study to answer this question will be available fairly shortly, testing 23 inhibitors again in axial disease, then you have the added benefit of not only not affecting inflammatory bowel disease in a negative way, causing like 17s, but actually treating the inflammatory bowel disease effectively. So each class has a tiny issue. One is an IBD aggravating issue, and the other is an absence of data for the axial involvement. So you pick the domain that's most important for your patient, and you treat aggressively and to bring the disease under control. And I think either agent has its large benefits, very minor downsides, and their safety is what's really made the big difference. Thanks very much.